I'm Brian Rini. I'm the Chief of Clinical Trials at Vanderbilt University Medical Center. Management of immune-mediated toxicity is certainly an important topic and one where knowledge has grown, I think, vastly over the last several years as these drugs have been introduced. I don't think the management of immune-mediated toxicity in kidney cancer is really that much different than any other disease to my knowledge. But the first step is certainly awareness, right? And when in kidney cancer, if we're giving a dual checkpoint inhibiting regimen, those patients are at much higher risk for immune-mediated toxicity than if we're giving one of our IO-TKI regimens. But either way, it can develop. Seeing patients frequently, giving them permission to call you at the first sign of side effects is important. Educating your nursing team is very important, and anybody who touches patients, including the folks answering the phones. Because it's clear that early intervention matters. And it really, the intervention is generally steroids first and then moving on to other immunosuppressives. And it's a matter of dialing that up and down and how intense do you need to be? How sick is the patient? Do they need immediate cessation of therapy, hospitalization, IV steroids, or can they be managed in an outpatient setting, say for a grade 1 or 2 rash and even, continue their therapy? There are well-developed and published guidelines from SITC, from NCCN, from ESMO, I'm sure from others I'm forgetting, that are largely overlapping, that are good to have on hand, that I keep on my computer desktop and in clinic to really sort of help me understand, what is the general advice for managing this patient with a grade 3 diarrhea. And then obviously tailoring that to the patient and the circumstance and comorbidities and, social circumstance and a lot of other things. But it's really awareness, early intervention. And I think the relatively, early use of steroids when needed. I think certainly personally in the early days, before I was adept at recognizing this, there were probably circumstances where I waited too long to give steroids. I'm much more liberal in giving that early now to sort of break the cycle of inflammation. I think there's to treat early and then try and taper quickly is a better strategy. In terms of considering rechallenge after immune-mediated toxicity, again, I think much of this is also contained in the published guidelines. The answer is, I think maybe probably yes, and it depends on the circumstance. So, for somebody with a grade 4 colitis to Ipi-Nivo, I'm probably done giving them Ipi. I might resume the Nivo depending on their disease status and fitness and other things. For somebody with a grade 2 rash, of course I would rechallenge or probably just treat through it. So again, it's severity of toxicity, it's fitness level of the patient. It's also importantly, and this just came up in clinic the other day, somebody who had toxicity after their 3rd induction dose of Ipi-Nivo and we're deciding on giving a 4th, and I said, hey, let's get a set of scans because disease status matters a lot. If they're responding wildly, then I don't feel compelled to push them to a 4th induction dose. I'd probably just stop and give them maintenance. Whereas if they're not really responding and I think they can tolerate it, I might do that. So not necessarily early on, but as you get later on, I might incorporate, a response assessment, at least in the equation of whether or not I'm going to rechallenge a patient. But I think that's very individualized to the patient and the doc. I don't think there are, firm guidelines in terms of rechallenge, but obviously it's like everything we do in medicine. It's a balance of benefit and risk.